Welcome to this video of nephrolithiasis. So in this video, I am going to talk about nephrolithiasis, its main point based on the theory and viva exams for MBBS. Okay, so let's start with nephrolithiasis. So the term defines itself that nephro means kidney and lithiasis means stones. So formations of stones in the kidney is nephrolithiasis. But in the exam, in the viva, what we get that the case we get it is actually the stone in the kidney. But the external or the teacher, they wants to listen the provisional diagnosis not as nephrolithiasis, but they want the diagnosis to be termed as urolithiasis. So if in exam you are given a case of nephrolithiasis, then do not say the nephrolithiasis, but rather say your provisional diagnosis is urolithiasis. Now after this, the teacher will ask that, okay, urolithiasis, then what is the most common site of stone where you suspect during your examination finding or from the history? Then after that, you mention that the pain is in the loin. Okay, the pain, then it radiates to the thigh region. It means there is the peristalsis movement in the ureter. So the most common site of stone in this case, it can be in between the pubes and vuse. Okay, in this way you have to explain. I will tell you later that, but I want to make you sure that do not speak the word nephrolithiasis, because because you are suspecting a stone, it can be in the renal tract anywhere. Okay, so the best term is the urolithiasis. Now talking about the nephrolithiasis, so the nephrolithiasis, it is most commonly present in an age group of 30 to 50 years. 30 to 50 years. And talking about the male is to female ratio, then it is 3:1, nearly 3:1. Now the stone formation that occurs in the kidney, it passes through the different stages. Okay, it passes through the different stages, and we have to know that stages. So the first stage is the supersaturation. First stage is like the crystal particles, okay, the molecules, like if it is the calcium phosphate stone, then the phosphate and calcium, and if it is calcium oxalate stone, then the calcium and oxalate first they saturate. Okay, first they saturate. So the term we use is, first is the supersaturation. Okay, supersaturation. And after supersaturation, they undergo the nucleus formation. They combine within themselves. Okay, they combine within themselves and they form the nucleus. Okay, then they form the nucleus formation. Like in the chemistry, we have learned that nucleus, proton, electron. Similar way, the nucleus formation occurs, and it acts as a nidus for the formation of stone. Okay, so after nucleus formation, these particles, they get accumulated, and what they form, and they form a crystal. Okay, and they form a crystal. So the third step is crystallization. Third step is crystallization. Now after formation of the crystals, many crystals they aggregate within themselves. Okay, many crystals they aggregate within themselves, and the term is aggregation. Now after aggregation, there occurs a matrix formation. Okay, there occurs a matrix formation. Now after matrix formation, what happens? The finally stone is formed. So if we talk about the stages of the kidney stone, then the first stage is supersaturation, nucleus formation, crystallization, aggregation, matrix formation, and stone formation. Okay, now we have to know that in gallstone disease, most of the stones are radiolucent. About 90% stones are radiolucent. But in nephrolithiasis, 90% of the stones are radiopaque. Okay, 90% of the stones are radiopaque. We have to know this difference between the GST and the nephrolithiasis. Now I would like to make one thing more clear, that which stone is radiolucent. Which stone is radiolucent in the nephrolithiasis? So the pure uric acid stones. Which stones? The pure uric acid stones. They are the one which are radiolucent in case of nephrolithiasis. Now let's talk about the different types of stones. Okay, different types of stones. The first one is The most common stone is the calcium oxalate stone. Calcium oxalate stone. So in which condition this calcium oxalate stone is found? So this is found in hypercalciuria, if calcium level increases. Hypercalciuria. The hypercalciuria, it can be idiopathic, okay? It can be idiopathic, or it can be due to hyperparathyroidism. Hyperparathyroidism, okay? And this one is the most common type of stone. Most common type of stone. And what type of stone it is? It is radio opaque. It is radio opaque, and it is found in the acidic urine, okay? It is found in acidic urine. Now the second type of stone is the calcium phosphate stone. Calcium phosphate stone. So calcium phosphate stone, is it radiolucent? No, radiolucent are only the pure uric acid stone, but the calcium phosphate stone, they are also radio opaque. They are also radio opaque. And what the difference between calcium oxalate and calcium phosphate? So it is formed in alkaline urine. It is formed in alkaline urine. Now the third stone, is the struvite stone. Okay, the third stone is struvite stone. So the struvite stones are those types of stone which are formed in the infected urine. Where they are found? So they are found in infected urine. What type of infection? So they are formed during the proteus infection. Why? Because this proteus organism produce a chemical known as urease. Okay, so what this urease do? This convert the urea into ammonia. Okay, now this ammonia get converted into ammonium phosphate. Okay, ammonium phosphate. Now in the struvite stones, there are usually combination of three types of stones. Okay, so the first one is the ammonium phosphate. Okay, the second one is the calcium phosphate, and the third one is magnesium phosphate. So it includes three type of phosphate. Okay, so this is called as triple phosphate stone. Also triple phosphate stone. So the struvite stone is also called as triple phosphate stone because it contains the calcium phosphate, ammonium phosphate, and magnesium phosphate. And here the organism proteus, okay, due to the proteus infection, it produces urease and it converts urea into ammonia, that later convert into the ammonium phosphate, and calcium phosphate and magnesium phosphate are present, and with the combination of this triple phosphate, the struvite stone is formed. And this struvite stone is also the radio opaque. Okay, no doubt, it is also radio opaque. Now the fourth stone is the uric acid stone. Okay, uric acid stone. Now we know that the uric acid stones, they are usually formed during hyperuricemia. So what are the condition of hyperuricemia? Like gout. Okay, like in gout. And these are radiolucent stone. And the fifth type of stone is the cystine stone. Okay, the cystine stone. What important thing about this cystine stone is these stones are the hardest stone. Okay, these are the hardest stone. One of the method of treatment of a stone is ESWL. Okay, by giving the shock waves. But as the cystine stones are so much harder, so due to its hardness, they do not break with the shock waves. So in such cases of cystine stones, we do not give the ESWL. Okay, so in this case, we do not give ESWL. What we give? We give D-penicillamine. D-penicillamine. Okay, no ESWL. Yes, it is the hardest stone. So is it radio opaque or radiolucent? Obviously, it is radio opaque. And the sixth stone is, it is the xanthine stone. It is xanthine stone. Now the xanthine stone, its composition is xanthine. Okay, its composition is xanthine, and it is also radio opaque. So we have to know about the different types of stones. Okay, so these are the different types of stone, and the most important is the calcium oxalate stone. It is most common type. Struvite stone, it is the triple phosphate stone, and the cystine stone, that is the hardest stone. And one more thing, that this Struvite stone, it is also called as the staghorn calculus. Okay, it is also called as staghorn calculus because it looks like a staghorn. Okay, now let's talk about the causes of renal stone. Okay, so the causes of renal stone. So as we can assume that the first one cause is the decreased water intake. Okay, decreased water intake. If there is a decreased water intake, then what happens? The crystallization, the supersaturation of the molecules, okay, it occurs very rapidly in the urine, due to which the stages of stone formation begins. Now, the second cause is the infection. Okay, second cause is the infection, like in UTI. If it get infected with streptococci, okay, staphylococci, or like in case of proteus, as I already explained. Okay, so this can also cause the stone formation. And the third one is, like, if there is the diet deficiency. Okay, if there is diet deficiency, especially vitamin A deficiency. So one of the function of vitamin A is formation of the epithelium. Okay, the vitamin A function is formation of epithelium, but if there is the deficiency of the vitamin A, then there is de-squamation of the epithelium, and that leads to the formation of nidus. Okay, and if the nidus forms, then the stone formation begins. So vitamin A deficiency causes de-squamation. Okay, this is the third point. Now the fourth cause is like hyperparathyroidism. Okay, hyperparathyroidism. In hyperparathyroidism, the hyperparathyroid, if the hormones producing the hyperparathyroid, sorry, the hormones producing this parathyroid gland, what it causes, uh, we learned a mnemonic known as SOT, yellow hotel. Okay, so if if there is hyperparathyroidism, then it causes osteoporosis, and if there is low, then it causes tetany. Okay, so in case of the hyperparathyroidism, osteoporosis occurs, and during osteoporosis, the calcium from the bones, they get demineralized. Okay, the bones gets demineralized, and the calcium from the bone, they are released into the systemic circulation, and due to the release of calcium in the systemic circulation, they also pass through the kidney, and in kidney they get filtered, and some maximum, initially less amount of calcium is to get passed from the kidney, but in case of hyperparathyroidism, there is a huge amount of calcium, so most of the calcium pass through the renal tubes, and what happens, there is a formation of the calcium. Okay, calcium stones, calcium oxalate, calcium phosphate stones in this kidney. So this is the hyperparathyroidism, and it is one of the cause of the renal stone. So how it is causing? It leads to hypercalcemia. And due to hypercalcemia, it causes hypercalciuria. And the fifth cause, we can assume that, is the decreased urinary citrate. So the citric acid, what it causes? Citric acid, it keeps the calcium phosphate. Okay, it keeps the calcium phosphate in soluble form. But if there is a decrease citric acid, then the calcium phosphate in soluble form decreases and insoluble form increases. Okay, so if the calcium phosphate in insoluble form increases, then it leads to the formation of renal stone. So these are the causes of the renal stone. Now we will learn about the clinical features of renal stone. Okay, so this is the urinary tract system. Now we will learn the clinical feature based on the site of the stone. So first, assume that the stone is here. Okay, stone is in the kidney. So if the stone is in kidney, most of the patient, they will be asymptomatic. Okay, they will be asymptomatic. Now if this stone it cross here, okay, if it crosses the kidney and it went into the renal pelvis, okay, when it comes into the renal pelvis, then the urine flow, okay, the urine which is flowing here, it gets obstructed. Okay, when it gets obstructed, then the urine starts filling here. Okay, the urine starts filling here, and it causes what it causes, it starts causing the hydronephrosis. It starts causing hydronephrosis. Now if there starts occurring the collection of urine in the kidney, then we know that the kidney is surrounded by different capsules, true capsules, false capsule, okay, renal fascia. Now this capsule will get stressed. Okay, what happens, this capsule will get stressed, stretching of capsule occurs. Now if stretching of capsule occur, then it will cause a dull aching pain. What it will cause, it will cause dull aching pain. Got it? Now assume that this stone has traveled, this stone starts traveling, this stone starts traveling, and it came into the site of the ureter. Okay, it came into the site of ureter. Now when it came into the site of ureter, then our ureter, what it tries to do peristalsis, and it starts pushing the stone into the urinary bladder. Okay, it wants to get relieved from the stone. So due to the peristaltic, the pain starts occurring again. And what type of pain occurs when the stone is in the um, ureter? It causes the ureteric colic pain. Ureteric colic pain. What type of pain it is? It is the pain, it is the very dangerous pain. Okay, the patient feels like he the dying is better than accepting such type of pain. Okay, one of my friend also was having this urinary colic pain, and he says that the we have given the ketorolac. Okay, we had given the PCM, ketorolac, and then diclofenac. Still the pain did not subside, and we have to give the opioid group of drugs like tramadol to get him relief from this type of pain. Okay, so these are such a dangerous type of pain occurs. Okay, so here what type of pain it occurs? It causes agonizing pain. It causes agonizing pain that radiates from loin to groin, or it can based on the sides. Okay, based on the sides and nerve involved, it can radiate to the tip of penis also. Okay, tip of penis, or in case of female, okay, vulva, as it starts moving distally. And when the patient is having the this urinary colic type of pain, then due to the peristaltic movement, the patient can also have nausea. Okay, the patient can have nausea, vomiting. Okay, his temperature might also it can raise. Okay, so fever can occur. Now the stone, assume that the stone has traveled a long way and it came into the this urinary bladder. Now again the patient will have any symptoms? No, the patient again it will remain asymptomatic. Okay, and sometimes it can irritate the bladder and it can increase the frequency of micturition. Okay, but if this stone starts traveling again and it comes into the urethra, okay, as the size of stone, it if I will talk about sizes later, but assume that if there is a relatively smaller, or in between is smaller and big stone about 6 mm, 7 mm, then it tries to pass through this urethra. Okay, and while passing, as the size of the urethra is smaller and the stone is a little bit bigger than the size of urethra, then the patient starts having trauma in the urethra. Okay, and due to this the patient will complain of hematuria. Okay, due to this the patient will complain of hematuria. And if in such case, okay, if in such case, if we do the urine routine examination, okay, then we can found the blood in urine, okay, then we can found the blood in urine, we can found pus cells in urine, pus cells in urine. So if any patient is having the pus cells in urine, do not always suspect that the patient is having some urinary tract infection, okay, rule out this urinary bladder stones also, okay. So the pus cells can also be increased in the this urolithiasis, okay, got it. And if the stone passes a long way, and if it crossed the urethra, then what type of symptom will occur? The patient will having the calciuria, patient will having calciuria, it means stone in urine, stone in urine. So in this way the clinical features of the stone occurs. And if we examine such type of patient, okay, if we examine such type of patients, and then what findings we can get. So the first finding which I want to make you know, that the first one is the renal angle tenderness, okay, the first one is the renal angle tenderness. So in exam the external asks that what is the site for the renal angle tenderness, then it is the, this is the 12th, and this is the sacrospinalis muscle, okay. So this is the sacrospinalis muscle, and this is the 12th last, okay. So if we thumb in the area between the 12th rim and the lateral border, okay, not the middle border, lateral border of the sacrospinalis, then the patient winces, and we can see the facial expression of having pain, okay, having tenderness in the renal angle area, okay. So in this way we can do examination. And if we palpate the kidney is usually not palpable, okay. If there is a hydronephrosis, then only it can be palpable. So kidney is not palpable unless hydronephrosis has developed. Now what is the next step then? The next step is investigation, okay, the next step is investigation. So we will proceed our topic with the investigation. So the first investigation we can do is the non-invasive and invasive investigation, okay. In exam we have to tell in this way, non-invasive and invasive investigation. So in non-invasive what we can send? We can send the first line as the X-ray KUV. Why? Because 90% of the stones are radio opaque except these uric acid stones which are radiolucent. So in X-ray KUV we can see the stones, okay, we can see the stones. So the first one, what we can say, we can send the X-ray KUV, and the second one is we can send the urine routine examination. I have already told that the stone can be found, pus cells can be found, okay, the stones can be found, the pus cells can be found, okay, and the blood, the hematuria, it can be found in the urine routine examination. Now after doing X-ray QV and routine examination, let us consider that the stone is not visible, okay. Then what we can do next? We can do the USG KUV. So in USG KUV we can found the shadow of the stones, okay. From USG KUV we can diagnose radiologically that the patient is having stones, and what is the site, okay, stones, okay, stones, and what is the site. But can we know the Hounsfield unit? No, we can't know the Hounsfield unit, okay, but we can know the stones and site from the USG KUV. Now if the patient is having pain, for example, if the patient is having pain and it is in the ureteric colic area, okay, if patient is having pain and it is in ureteric colic area, and his renal function test, if we have done the renal function test and the creatinine level is more than 1, okay, and suppose it is 1.9, creatinine level is 1.9, and the patient is in pain, what treatment we have to give? Should we give the NSAID? No, we can't give NSAID, because this NSAID can cause the nephrotoxic injury, and it can aggravate this AKI, okay, it can aggravate this creatinine level, okay. So what we prefer to give in such type of patient, we have to give the opioid groups of drugs, okay, to relieve the pain. So in the non-invasive investigation, though RFT is an invasive investigation. We have to send in the first line, okay, we have to send subsequently with the urine routine examination, USCKUB, and this renal function test. It is in invasive. Renal function test is the invasive procedure, but as a clinical approach, we have to send RFT to see for urea and creatinine level. Now, after sending the X-ray KUB, urine RE, USC KUB, and RFT, what other investigations we can send? So, if we have concluded that in USC KUB, okay, in USC KUB there is a stone, and there are and the site is also mentioned, but like if the stone is 20 mm, okay, if the stone is 20 mm or 5 mm, then what further investigation we have to do? So I will list out that. So the first one investigation we can do is CECT, sorry, NCCT. It's not CCT, it's NCCT, non-contrast CT scan. So from NCCT KUB, what we can see, we can see what is the number of stones, okay, what is the number of stones, what is the site of stone, okay, and what is its Hounsfield unit, and what are the associated complications, like from uh, uh, this renal stone, it can cause hydronephrosis, we can see that. And the fifth one, what we can see from NCCT KUB, it is the distance, from skin to stone, so these are the things which we can see from NCCT KUB. Now, talking about the treatment part is the most important part. So always say the treatment in the four topics, okay. The first one is the general measures, okay, and the second one is the definitive treatment, third one is the treatment of complications, and fourth one is the prevention. So these are the 4 points under which every examination treatment should be told, and if we say these 4 points, then the examiner gets impressed and gives good marks, okay. So in the general measures, what we can do, like the patient has come with the pain, okay, the patient is having pain, so what we can do, we can give for the pain, what we can give, analgesics, okay. For pain we give analgesics, and we can encourage patient to drink water, okay. Like if the patient is having pain, then if we encourage the patient to drink water, then what happens, the urine formation occurs more and the stone gets passed, okay. Or in the second hand, what we can do, we can add NS to the patient, okay, to increase the blood volume and finally formation of urine more, okay. So the first general measure what we can do, the most important is this pain management with analgesics. Now what type of analgesics we can give the patient, like PCM, okay, PCM 1 gram IV stat we can give, okay. If the patient is not subsiding pain with this PCM, we can give injection diclofenac, okay, diclofenac. If again the patient is not having if the patient is not responding to the diclofenac, then we can give also the ketorolac, okay, if not, we can give opioid groups like tramadol, okay, they can give tramadol plus 100. So in this way the pain management can be done. Now the definitive treatment, most important part is the definitive treatment. So for the definitive treatment of the renal stone, what we have done, the NCCT. The NCCT. Now on NCCT, if stone is of any Hounsfield unit, no matter it is 1000, 2000, any Hounsfield unit, if stone it is less than 5 mm, okay, if it is less than 5 mm, then what we have to do, we have to give medical expulsion therapy. we have to give medical expulsion therapy. No need of any surgical intervention, but we can simply give medical expulsion therapy. So for that we give tamsulosin. For that we give tamsulosin 0.4 mg, okay, at bedtime. At bedtime, and it is given for 3 weeks, 3 weeks, and then follow up the patient. Okay, so if stone is less than 5 mm, what we can give? We can give medical expulsion therapy, tamsulosin 0.4 mg, then we can follow up the patient. Okay, and with this we have to give the pain medication, which I already told, pain medication, and we have to encourage patient to drink water. Now, for example, if the stone, if stone is, if stone is 5 mm to 25 mm, 25 mm, okay, but the Hounsfield unit is less than 1000, then what treatment here we can give? We have to give here the ESWL. What? ESWL. What it is? It is extra corporeal shock wave lithotripsy. Okay, it is extracorporeal shock wave lithotripsy. Now, for giving this ESWL, what are the things we have to consider? Okay, for ESWL, the skin to stone distance, it should be, skin to stone distance should be less than 10 centimeter, because we are giving shock to the stone so that they get fragmented, and the stone, after fragment, it becomes in smaller size and it passes. Okay, it passes. But for giving that shock to the stone, okay, for giving shock to that stone, the distance from skin to stone should be less than 10 centimeter. And is there any contraindication? If it stone is 5 mm to 25 mm, in between 5 to 25 mm, and Hounsfield unit is 1000, less than 1000, though the criterion meets, but there are still contraindications, like in case of pregnancy, we cannot give the shock wave. Okay, if the patient is having any bleeding disorder, and if the patient is having aortic aneurysm, more than 2 centimeter, then this ESWL is contraindicated. Now let's talk about the complications. Okay, let's talk about the what type of complication can occur while giving this ESWL. Then there is a formation of stone street. Okay, there is formation of stone street. In X-ray we can see there is a stone street that is known as Cystine stressy, and the second one is it can cause hematuria. So these are the two important complications of ESWL. Now the third condition is like stone is 5 to 25 mm, but its Hounsfield unit is more than 1000. Okay, initially it was less than 1000, now it is more than 1000. Then in that case we will prefer to do RIRS. Okay, what we will do? RIRS means retrograde intra-renal surgery. Okay, and when this ESWEL is contraindicated, in that case also we go to the RIRS. Okay, now the fourth condition. Is like what happens if the stone is more than 25 mm. Okay, more than 25 mm means more than 2.5 centimeter. Now when the stone is more than 2.5 centimeter, then what we do? We go for PCNL. That is percutaneous nephrolithotomy. Okay, percutaneous nephrolithotomy. Now in cases of like large stones, in cases of if the stones are much more larger than this, more than 2.5 centimeter, or it is 3 centimeter, 4 centimeter, which we cannot do PCNL, then in that case we prefer to do open surgeries. Okay, in that case we prefer to do open surgery. So what are the different types of surgery? There the nephrolithotomy. Okay, we can do nephrolithotomy, we can do pylolithotomy, okay, and we can do extended pylolithotomy. Extended pylolithotomy. Extended pylolithotomy means nephrolithotomy plus pylolithotomy. Okay, so we can see from this figure also that if the stone is in this renal cortex, okay, if it is in renal cortex and it is larger, then we can do the nephrolithotomy. If it is in pelvis, okay, if it is in pelvis or in this ureter, we can do pylolithotomy. Okay, and the extended pylolithotomy means ureter, sorry, this pelvis and renal cortex, if stone is present in between them. Okay, or if we cannot operate on the nephrolithotomy, then we can do extended pylolithotomy. Now our third point was that the treatment of complications. Now when this renal stone formation occur, then it can also cause UTI. So for that we have to give antibiotic. Okay, for that we have to give antibiotic. It can cause hydronephrosis. Okay, it can cause hydronephrosis, and for hydronephrosis we have to do DMSA scan occur. Okay, dimercaptosuccinic acid scan, or MAC3 scan. Hydronephrosis is a big topic, we will discuss it later, but just I am saying the investigation what we do. So one is DMSA, MAC3, one is CTIVU. These are the investigations which we do in the this hydronephrosis. Okay, and this hydro echo, and after the investigation the appropriate management is done, and similarly other complications of renal stones are also treated. Now the fourth point is prevention. So how can we prevent? How can we prevent? Simply just drink more water. Okay, just drink more water. And if the renal stone, like if the renal stone is in this ureter, then uh, jumping movement like skipping, okay, jumping, skipping movement, it also helps in passing the stone through the ureter, okay, through the ureter to the urinary bladder. And what are other prevention? Just vitamin A deficiency prevention, okay, vitamin A deficiency prevention, and then prevention of uric acid, okay, uric acid. And we have to treat the cause also. Okay, we have to treat the cause also, like if it is the stones are formed in gout, like hyperuricemia, uric acid stones, then we have to control the uric acid also. Okay, so in this way cause also needs to be treated. So in this way the topic of nephrolithiasis is completed. But in case of urolithiasis, okay, but in case of urolithiasis, suppose if stone is between PUSA, pelviureteric junction, and VUSA, okay. If stone is between PUSA and VUSA, then we do ureteroscopy plus lithotripsy. Okay, now assume that if the stone is in bladder, okay, if the stone is in bladder, then what we have to do? Okay, if stone in bladder, then if it is 4 mm, then simply what we do, medical expulsion therapy, or simply it will pass. Okay, but if it is less than 2 centimeter, then what we can do? We can do cystoscopy plus lithotripsy. Okay, lithotripsy, or we can do cystolithopaxy. And if it is more than 2 centimeter, then what we have to do? We can do open cystolithotomy or vesico or vesicolithotomy. Sometimes what happens, the stones are present in this here, they are present in the renal pelvis or in the upper ureter. So in that case what we do, we just push the stone to the cortex. Okay, we just push the stone toward the pelvis and then we bang. So what is the treatment? That is push and bang. Bang means ESWL. So at first what we'll do, we will push the stone and then we will bang. Okay, so if stone is near the pelvis, if stone is near the pelvis, what we do, we do push and bang followed by ESW. Okay, so with this the topic of renal stone is completed. Hope you enjoyed the video, and if you have any doubt then you can ask in the comment section, and please do not forget to share this video with your friends. Thank you.